So seeing as this is now the second video that I have filmed literally while sitting at the curb by my car over there at the clinic, maybe we will call these segments curbside with the doctor. But I want to talk about a patient that I have and in the regen space, and something that comes up a lot that I think is really important to talk about, and it's this notion around treating pain generators and looking at our outcomes on our procedures in order to guide our treatments. So I have a gentleman. He is in his 60s, and he's been seeing another doctor for injections for the low back. So patient has low back pain. To give you a little bit of history, it is worse bending forward. It is better in extension. So already I'm thinking that it's not the facet joints, because remember, the facet joints are generally going to be worse when we go into extension, we go up, and better when we flex forward, based on the angle of the facet joints and the mechanics of what happens in the low back when we do that. So his was reversed. So it was better with extension and worse with flexion. And so already there, you could be thinking there might be some cluneal neuropathy, because as the cluneal nerves get stretched, they can become painful. You might have some discogenic pain, right? Because as you go into flexion, what happens is the posterior aspect of the disc has a little bit of strain put on it as the disc space is opening up. And so it could be some mild discogenic pain. Those are kind of the two big things that I had thought about. And then also, third was the inflammation of the posterior rami, so basically the dorsal root that is coming off of the spinal cord that basically gives off the branches that then innervate the rest of the back. So tying that story in, that's what's going on with him. He was seeing another doc in town for prolotherapy, PRP of the low back. And first off, this doctor sold him three PRP procedures right up front before ever seeing if even the first one worked. So that's a problem with me, and that is not something I ever do in practice because of a few reasons. One, what if that patient is 100% better or near 100% better after one treatment? Now you're in a situation where you've either got to refund them, or what some doctors will do is they'll say, oh, well, let's do one additional more as insurance that this is going to stick. I'm sorry, if somebody after 3 months is 95% better, I don't think you need to do an additional injection as insurance that it's going to stay better. You just wait to see if it ever regresses, and then you do it again. So that's one of the issues. The other issue is that what if the first one doesn't work? Then what are you going to do? Do a second? What if the second one doesn't work? Do a third? And now all of a sudden you've got 3 PRP procedures or whatever procedures that don't work. And so how are you going to rectify that, right? So this patient had 2 out of 3 procedures with 0% relief, 0. So he was in that latter camp where he would have just gone on, had his third, because sometimes what will happen in these situations is doctors will say, oh, sometimes we need to do 3 in order to see a change. No, that's BS. If you actually find the pain generator and you inject that pain generator, you don't have to inject it multiple times in order to see an initial response. The first time you inject it, you will see a response. It may be a small response. It may only be 10% improvement based on the severity of the injury or whatever tissue pathology is going on. But this whole concept of, you have to inject something multiple times before you even see a response is complete BS. So he comes to us to kind of get a second opinion on what's going on. We do the physical exam. I talk to him what I think about is going on, right? Kind of those 3 possibilities. Some cluneal entrapment, right? His superior and middle cluneal nerves were very, very large on palpation. And so we know that there's some inflammation going on in those nerves. There's the possible discogenic pain, and then the neurogenic inflammation of the medial cutaneous branch off the dorsal rami, which again supplies the skin over the back. And so we decide on our procedure, a single procedure. We're going to do a caudal epidural which I think will help with the if there is any discogenic pain. And we do use PRP for this. And then we did a nerve hydrodissection of the superior and middle cluneal nerves. The superior cluneal nerves, basically in the region around the iliac crest where they are crossing over. And then on the middle cluneal nerves, just lateral to the lateral edge of the sacrum where they are coming through and piercing that gluteal fascia. So we did those. And then we did what's called an erector spinae plane hydrodissection, which basically we have the erector spinae muscles, and then we have the transverse processes on the low back, and we inject in the fascial plane between the erector spinae muscles and the transverse processes of the lumbar vertebra. And what we basically get is we end up bathing the dorsal root ganglia at multiple levels on each side. So we do that procedure on Friday, and we spoke with the patient today. Today's Monday. Obviously, you guys won't be watching it on this date, most likely. But basically, 3 days later, our patient is 100% pain-free at this point. He has zero pain, which that might not last, right? Sometimes patients get a really strong anti-inflammatory effect initially from our injections. There was a mild amount of local anesthetic in our nerve hydrodissections, but that would, if this response were only due to that, his procedure was end of day Friday, so it would have worn off at the latest by middle of the day Monday, middle of the day Saturday, and is now end of day Monday. And so we know that it's not just a local anesthetic effect. So that it might wear off a little bit, but the fact that after one treatment, he has seen improvements when 2 other treatments with another doctor have seen 0 treatments. It's a huge testament to the importance of a physical exam and trying to determine what's causing the pain and then actually trying to treat that pain. This is the way that regenerative medicine has to be done. We have to move away from just treating all low back cases with peppering of the facet joint and the lamina and the sacroiliac joint and the supporting ligaments, and moving towards what structure is causing pain and what can we do about it to explicitly and specifically treat that pain. So just my curbside thoughts for the day. I hope everyone is having an amazing one today, and I hope you're all on your way to becoming pain-free. See you later.